Hello, today we are going to speak about the physiology of intracranial pressure in children. It is an important topic which has many implications in different domains in pediatric neurosurgery. So first, what are the units in which we measure the pressure? The international unit is the Pascal, because Blaise Pascal used to work a lot on pressure. He was a pioneer in this domain. He was very popular in France a long time ago, before the introduction of the euro. Then there is the centimeter water, which is very handy, and is 1 centimeter is almost equal to 1 hectopascal. Then we have the millimeter of mercury, which has the name of Torricelli, who invented the mercury barometer. Then we have the atmosphere, which is more atmospheric use in meteorology. And in the imperial system, the pound per square inch, which is not very used anymore, except in garages. And both these units are not used for ICP. We mostly use the centimeters of water because it is very handy when we have when we use catheters, and the millimeter of mercury, which is used for precision measurement tools. So what are we measuring? In fact, we are not measuring pressure, we are measuring gradients. And this is a metaphor I took from my master, Christian Saint-Rose. These are scuba divers. They are in a wreck at 50 meters deep in the Bay of Saint-Pierre and Martinique. And the pressure is about 6 atmospheres, that is the ambient atmosphere plus 5 times 10 meters. So the pressure is about 560 millimeters mercury, which is huge, but everything is well. They are a bit narcosed because nitrogen has funny properties at that pressure, but they are very well because the pressure is the same everywhere in the ambient environment, in their venous blood and in the brain. Then we have this patient with communicating hydrocephalus. If we measure his ICP, it is very high. It can be 40 millimeters mercury. However, he can talk with you. He's not so bad, except that he may become blind because there is a gradient which exercised at the outlet of the skull in the optic canal. Then we have this patient with obstructive hydrocephalus, who comes in a coma. But if we measure the ICP, it may be low. And when you do the ETV, which will save his life, you may note that the brain can be 1 centimeter away from the dura mater. And in fact, he's in a very bad shape because there is a gradient inside the brain which affects on the mesencephalic structures, which are very important for vigilance. So the quidera demonstrandum is that the question is the gradient, not the pressure. This is the meaning of the lesson by the master. So how do we assess the ICP? The fundoscopy is very much used, but it's unreliable because there are a lot of false negatives. It is considered to be positive in only 25% of patients having intracranial hypertension. And it has also a few false positive, like this drusen, which has to be known by the ophthalmologist who do the fundoscopy. We use the Doppler, which is very useful. However, we have to remember that it is indirect, and in fact, it reflects the hemodynamics, which itself reflects the pressure. Then we have the diameter of the optic nerve sheath, which can be very useful, but not so easy to do in small children. We have the historical use of the lumbar puncture, which is still used, but it's not always easy, and it is just one measure at one point in the day, and it can be contraindicated in some patients. And finally, the reference method is the intracerebral fiber, which is invasive, but can allow prolonged periods of measurement. So what do we get? We have this kind of waveform with three spikes, the percussion wave, the dichrotic wave, which represents the recoil of the blood after pulsation, after the systole, and then the tidal wave. And this repeats, and when we have intracranial hypertension, we can see that the shape of the waveform changes in the lower line. We note that when we do monitoring that there is a little delay between the systolic spike in the blood and in the brain. And we have also to see that this waveform changes when the patient coughs, when we compress the jugular, and so on. Then we have a secondary cycle, which corresponds to breathing. When we inspire, the pressure drops. When we expire, there is a surge in pressure because the venous pressure increases and it transmits it to the brain. Then we have tertiary cycles, which represent the brain activity during wake, during deep sleep, during REM sleep. It has been shown in this quasi-experimental study a long time ago. So it reflects the activity of the brain. Then this pressure translates into pulsation, which we see very obviously when we open the dura. However, when the brain's envelope are closed, it does not expand outside. It leads to movements of fluid. So where does it come? It comes from the heartbeat. It has been shown by experiments by Ezio Di Rocco with this kind of document in case of plexectomy, which shows that in experimental hydrocephalus, the dilatation of the ventricles can be diminished by plexectomy. Or the reverse, he created a beautiful model of a balloon which inflated with a pace made on the heartbeat. And this is something we can see in shunted patients. When we put a shunt, we create a sink of pulsatility, which leads to a smaller ventricle on the side of the catheter. So what effect of the pulsatility has been said to have an important hemodynamic effect, the Windkessel effect, which creates a sort of massage of the vein, which helps to brain circulation. It has also been involved in the calvarial growth, as we shall see. And so where does it go? There is a pulsatility sink where the place where the envelopes and the dura mater are compliant. That is the cisterna magna and the spine. And this can be shown in this cinetic MRI in a patient who had a Chiari. What is normal? The normalcy varies. It varies with the hemodynamic conditions, with the blood volume in particular. Our anesthetist knows that very well. With the venous pressure, and when there is a CPAP, for example, we have to deduce the value of the CPAP from the ICP we measure. And it can also increase with the abdominal pressure in case of pregnancy, of obesity. This is an obese teenager who had a Chiari caused by the pseudotumor cerebri, due to the obesity. And this is a baby who had a shunt with dysfunction when he had a very severe meteorism. And this gives an idea of what happens when we are straining, for example, and the impact of straining on ICP is certainly a reason why we cannot strain too long. So it changes also with age. During infancy, the child acquires a upright position. That means the ICP can become negative and the calvaria becomes rigid. This is an integrated process. During old age, we know that CSF output declines. And also in utero, there is an age when the hydrodynamic is completely different because there is an outer contact pressure, and it has been measured that the pressure diminishes during pregnancy from 9 millimeters to 5 millimeters mercury close to the time of term. So how does does it impact the hemodynamic in the baby? It has been much studied by our colleagues obstetricians. In fact, there are adaptations like the trigeminal complex, of which we are going to talk in a minute, and a rise in pressure. And in fact, the findings of these researchers was that there was no evident link between the rise in pressure in the amniotic fluid and the bradycardia in the fetus. And bradycardia was probably due to other causes like pain. And the perfusion is maintained. Remember the divers. So normalcy varies again with activity, with pressure, with a posture, with gravity. And these are results from a study done by space researchers regarding the ICP in low gravity. First, with increased gravity, we see that the ICP rises, but not so much. Then when we lie down, it has the same effect. The ICP will rise, but it will be compensated after some time. And then these voluntaries where the patients were studied had a reservoir implanted for treatment of leukemia, and they were survivors of leukemia, and they volunteered for these studies. And they were also offered a zero gravity experience because the question was whether there would be a risk of vision impairment in cosmonauts, and where would the pressure rise in zero gravity. And in fact, the measurement done during this zero gravity episodes showed a lowering of the ICP rather than a rise, but it was a very short period. So the question remains. Then we have physical activity. I already spoke about straining. There is a sneezing, which can raise the ICP very much. Exertion, prolonged decubitus in our chronic patients. And brain activity, I already mentioned, during wake, REM sleep, and deep sleep. So ICP is mostly important, as you know, because it impacts the cerebral perfusion pressure, which is the mean blood pressure minus the ICP. That is, the ICP plays the role of a post-charge, which prevents the blood from circulating. And if the ICP is equal to the mean blood pressure, of course, it leads to brain death. There is a stop of circulation in the brain. And it has been known since the day of Harvey Cushing, who gave his name to this reflex, that raised ICP caused raised blood pressure. And this is a Cushing reflex which must be respected to allow the brain to be perfused. But we know also that the compensation has some physiological limits. And this is a complex graph from Czosnika showing the reactivity of hemodynamic to ICP. And we know that if the ICP becomes indexed on the blood pressure, this is a very bad sign for these patients. So how does this perfusion translate in practice? We know the Starling curve, which shows the pressure-volume correlation with some compensation for some time. And then when the buffer mechanisms are overcome, the pressure rises. And then the elastance of the brain increases a lot. That is, the brain becomes less compliant. And we know that this curve is even straighter in children. The rise is stiffer and earlier because the child's brain is less compliant. So autoregulation, we know more and more that it is regulated by the trigeminal vascular reflex, which allows the vasodilatation in reaction to stimuli in the sensory divisions of the trigeminal nerve. And especially, there is a release of peptides coming from gaseous ganglion by antidromic conduction of the sensitive fibers. And there may be also a role of the corticodural veins around which has been shown by a French team in 2007 the existence of muscular fibers around the junction of the veins with the sagittal sinus, playing the role of like a sphincter with a disposition close to what we find in the genital organs. So finally, we have a steady state, which is in fact a dynamic balance, balance between blood perfusion and drainage, between the content and the container, and between CSF secretion and absorption. And this is another gift of Christian Sainte-Rose, who created this very simple yet very illuminating graph showing the relation between secretion and reabsorption of CSF relative to the pressure, and the crossing of these two lines represents the balance between secretion and absorption and the steady state in which we are living. So another one of my masters was Jean-Pierre Siches, who created this diagram showing the different elements of the content of the skull, which are the CSF, the blood compartment, and the venous, the tissue compartment. And these different compartments can be increased or decreased in different conditions. And in the end, it is a zero-sum game, because when one compartment increases, it is at the expense of one or two others. However, this rearrangement comes at a price, that is, that the pressure will increase. So in children, there is a specificity, which is growth. That is, if pressure increases, the content will be able to grow more. And this normally leads to harmonious growth of the skull if there is adequate pressure. It helps to normal calvarial growth. If the pressure is little bit too high, it may lead to an excessive increase, like in this baby who developed a Sylvian arachnoid cyst. This is a kind of head circumference curve we can see in these patients, which rises from 1 or 2 standard deviations around the age of 6 months, then stabilizes. Conversely, if we have a too low pressure, like in this patient who had a shunt, it can lead to a progressive closure of the sutures and a stagnation of head circumference. In this view, idiopathic macrocrania shows there is a mismatch between CSF secretion and absorption, between pressure and growth. We see that the head circumference increases regularly, then tends to stabilize around 2 years. We know that it is due to an expansion of the arachnoid space, which is filled with normal CSF. And it may be caused by a delayed development of arachnoid granulation, or too early increase of the CSF production. And Patrick Delem proposed that it could be considered like a sutural disorder with excessive cellular response to the stimulus of pressure. More food for thought is to reflect about the posterior fossa. When you have a Chiari, the cerebellum is compressed by the skull. It is the reverse when you have Dandy Walker, because of, the posterior fossa is ballooned by the cyst. And regarding the calvaria, when you have a pseudotumor, the brain is compressed. And while when there is an external hydrocephalus, the calvaria becomes expanded. So we can wonder if there is a difference due to age, but not just because we have these different conditions that occur at the same age, or because there is a different pulsatility of the CSF or the brain stimulating the bone growth. Finally, what is the value of ICP measurement? We have said that we have to think about the relation between content and container, phenomenon of resonance, the growth. We have also to take in account the duration. I've said already, but it has been shown that the more sustained the duration of ICP, of raised ICP, the more deleterious it will become. And we know that in physiology, we can have very high ICP, but for very short periods, like when we sneeze, for example. And all depends on the context. You see on this curve, it looks normal, but why did we put an ICP? Because the patient had an encephalitis, he was on external drainage. So obviously the curve of ICP cannot be interpreted out of its context. And finally, we may reflect, is a normal pressure value a neurosurgical fallacy? It is certainly an easy variable to measure. In the 50s, we designed pressure-regulated valves, which needed to be adapted in the 90s by adjustable devices, in the years 2000 by anti-siphon device. But as early as the end 80s, flow-regulated valves were produced, which, in my view, are much closer to the physiology of a CSF and ICP. However, these valves did not catch up and are in the process of being phased out by the industry because they are not profitable. And it reminds of a history of wrong technological choices, like in the 19th century, the QWERTY keyboard we are still using was designed to slow down the typing to avoid the jamming of keys. And during the 20th century, the electric grid in Europe after World War II was rebuilt with 220 volts, which causes many deaths, because it allowed to convey twice as much energy with the same cable. So, on this we shall conclude that ICP, the normal ICP is a variation between limits, physiological limits. ICP is more than a figure. It has to be confronted to the variations in duration. It has to be put in relation with the physiological activities of the brain, of the whole body, and related to hemodynamics and related to growth. I thank you for your attention.